Hello, everyone. Welcome to Nestlé Health Science's Women's Health Educational Webinar focused on sex differences in brain aging. It's wonderful to have so many healthcare professionals joining us from across the world today. Before we begin, I would just like you to take a look at our disclaimer, just to get this out of the way. Of course, this webinar is for health professionals only and is for educational purposes only. We will be sharing a copy of the recording afterwards, which will be available on demand. So anybody who would like to see this as well, you're more than welcome to view this in the platform later. But as I said, a very warm welcome. My name is Rowena Thompson-Slebowitz. I am the Medical Affairs Lead for Nestlé Health Science for the Women's Health Platform, and I will be your host today. So, of course, as I mentioned, today's webinar focuses on sex differences in brain aging, and we are absolutely honored to have Dr. Antonella Santuccione-Chadha with us, who is a leading expert in women's brain health. And of course, I will tell you much more about Dr. Antonella in a bit, but she'll be sharing the latest insights into why women's brains age differently and what we as healthcare practitioners can do to support our female patients through menopause and beyond. So helping them be empowered to live a full and healthy life as we transition through menopause and beyond. So really looking forward to this presentation from Dr. Antonella today. But before we begin, I also need to just share some general housekeeping with you. So for those of you who are not that comfortable in English and would prefer to follow the webinar in your own native tongue, please note that we do have Wordly AI translation available. So just make sure you're activating this on the platform and you'll be able to listen into the webinar using your language of choice. And then, of course, we'd love you to ask as many questions as possible. So please submit your questions through the Q&A section of the webinar. And there will be one or two polls. So please, of course, participation is optional, but we'd love to know your input. So if you feel comfortable, please answer the polls with us. And then for those of you who may want a certificate of attendance after the webinar, please complete the feedback form provided and a certificate of attendance will be shared with you. And then just a reminder that we do also have a resource page where we have lots of useful information on products available for women's health at Nestlé Health Science. So for those of you who would be interested in looking at some of that, please feel free to visit the resource page afterwards as well. But before we go any further, what I would really like to do is introduce you to Gillian Aiken. Gillian is our Director of Women's Health and Portfolio Management at Nestlé Health Science, and she'd like to share a few words with you. So I'll hand over to Gillian. Welcome, Gillian.
Thanks, Rowena. Can we advance the slide? Thanks. So just a few stats, I think, to reinforce why we're all here today. So can you believe that it wasn't until 1972 that women were medically cleared to run marathons? Women couldn't get a business loan in the United States without their husband co-signing until 1988. And it wasn't until 1993 that the NIH required women to be included in research. And we know that women are still woefully underrepresented in health research. And it was only 3 years ago that real blood was first used to test menstruation products. So it's clear that women's health needs have been overlooked. And that's why we're here today. We're excited to partner on this journey to change that. Our esteemed speaker is going to share information and insights that will enlighten you on important sex differences in brain aging. I know a topic that is probably dear to many people's hearts. And excited to hear from Dr. Antonella shortly, but first I will turn it over to Rowena to kick things off.
Thanks, Gillian. So what we're going to do now, if everybody is comfortable with this, we're going to launch some polls. It's just 3 short questions we would like you to answer. No wrong answers, right? So first question is, before today, I routinely considered sex and gender differences when screening midlife women for cognitive symptoms. Yes or no? It takes a little bit of time for us to collate these results, so please just bear with us, but any insights you have here? Right, so getting lots of answers, so that's great. Give it another couple of seconds before closing the poll. There's quite a lot of people on the call, so we'll just give everyone a chance to answer. Right, so I'm going to close this poll because we've got quite nice answers. So actually 63, oh sorry, now it says changed to 61% actually say, no, you haven't considered sex and gender differences when screening women in midlife. So, you know, and I don't think this is uncommon. And this is really one of the things that Dr. Antonella is really here to discuss with us today. You know, this is really, really critical. Women should really be screened and tested and considered differently to men when it comes to cognitive symptoms as we get older. So that's the first one. And then I'm going to launch the second poll as well, just to see how you feel about this one as well. So this one is yes or no. Before today, I routinely considered, sorry, I didn't change the slide. So women may perform better on verbal memory and early Alzheimer's disease, which can mask early disease or standard screening methods, yes or no. So let's see how you all do. This is great. So most of you said this is true, and that's absolutely correct. So that's great news for us. We're glad to know that this is something that all our practitioners are looking out for. And then for the final poll, true or false, postmenopausal status is associated with higher tau burden and faster cognitive decline compared with men. I promise I'll hand you over to Dr. Antonella soon. So the waiting is nearly over. Fantastic. Everybody says, well, the vast majority say true. So that's good news as well. These are things that we understand already. So Dr. Nella, some of your job is already done, but I'm sure you're going to help us to understand this much better as we go through the presentation today. So thank you very much for everybody who participated in the polls. I really appreciate that. And so without further ado, here I would like to introduce you to Dr. Antonella Santuccione-Chadha. We are incredibly honored to have her here with us today. She's a leading expert in women's brain health, and she will be sharing insights into why women's brains age differently and how we can translate this knowledge into better care for our patients. I would encourage you to ask as many questions of Dr. Antonella as possible by popping your questions in the chat. But I really would also like to say that Dr. Antonella is, you know, an incredibly esteemed leader in the field of women's brain aging. She is a medical doctor, a neuroscientist, and of course, she is the founder of the Women's Brain Foundation, where she champions research into how biological sex and gender influence brain and mental health in women. And she works to drive progress in neurological and psychological care, and her contributions to women's brain health have actually meant she has several international honors, including the Women of the Year in Switzerland and the Veuve Clicquot Bold Women Award. So we are so grateful for Dr. Antonella's time today, and I've been through the presentation a little and it looks incredible. So really can't wait for Dr. Antonella to share her pearls of wisdom with all of us. Thank you so much, Dr. Antonella, and it's over to you.
Thank you so much, Rovina. It is a joy to be here with you today and be a host from the Nestlé Health Science. I also would like to spend a few words of acknowledgement to all the colleagues in the room, because to take the time and listen to the scientific advancement fostered by the Women's Brain Foundation, of course, makes me very proud. And thank you so much. I hope that this scientific insights that we will share with you will help you in, of course, managing patients wherever you are. And we're going to have a conversation on how sex and gender impact brain aging. And it's about what each of us should know and hopefully do to foster what we define the women's brain capital, and more in general, the brain capital of each of us. It's going to be a discussion, as we heard, about menopause, lifestyle, and finally, women's brain health. Just two disclosure about me. I am the founder of the Women's Brain Foundation, as you heard already, but I also act as a mentor for InnoSwiss, which is a Swiss governmental agency for innovation in the country, and I'm the vice president of EU-Research, another governmental agency that fosters research and collaboration across academia around the globe and Switzerland, of course. Now, before we proceed, I think one question we need to ask ourselves, it's really what we mean with sex and gender and how they both determine our health. Actually, what we know is that, of course, sex, it's about our biological component and what it's embedded and encoded by our chromosomes, how they do shape our phenotype with our reproductive organs, genitals, and the biological functions we bear as men or women. But it's also about the hormonal settings we produce, the proteins, the microbiome, so how our DNA really impact our essence and our determinants of health. And then there is gender. Gender, it's more of an abstract concept and might differ across the globe, across geography, across cultures. Nevertheless, it is what we as humans attribute to an individual as being male or female, or what an individual decides to feel like. And this also has an implication on how we stay healthy, on how we disease, and how we age. For instance, let's look at the burden that caregiving worldwide has on women. We know that caregiving, it is mainly a female role, and predispose also women to certain type of works and jobs. There are attributes that comes with gender. For example, women being more fragile and emotional, or men being more risk-taking and aggressive. And finally, there is also the entitlements that it takes with being either female or male. And this is reflected then into access to healthcare, into financial independence, or, you know, how women might participate less into the workforce and vice versa. Men are more and longer active in terms of working forces, and they have a stronger financial autonomy, which also leads to a better access to healthcare solutions. Now, the problem, in fact, is that neither sex nor gender has been really considered in the way we do develop solutions for humans. Mainly, the approach has been that the male body has been the default model for developing biomedical research as well as care. And we know that women are less represented into preclinical research and clinical research. I give you an example. There was an important publication on Cell referring to metformin, which is a compound prescribed for diabetes, and it was claiming that in monkeys it was able to rejuvenate brain. This was a Cell publication. Now, what if I tell you that the animals included in the study were just male animals, so male monkeys? And this is a missed opportunity to understand how a solution can also act on the brain of a woman, or in general, on the body of a woman. It's an old problem, and finally we're trying to solve it. I think that's also why we are here today. In the end, it has tremendous implication on how we allocate our resources, on how we design our clinical trials, and how patients benefit of a given solution. This is data extrapolated by the McKinsey report that was launched at the World Economic Forum 2024. Here you see that majority of the drugs that were withdrawn from the market, almost 21% of those, it was because they had side effects on the female population. So they were women's health risk related, just 6% on men, And the rest was either not disclosed or not better, or data were not available. So what I'm trying to tell you is that we need to have a sex and gender tailored approach to have precision medicine to benefit patients, to reduce costs and minimize risk for each of us. And this is the work that is conducted at the Women's Brain Foundation. Now, when we look at brain and mental diseases, what we have to keep in mind is that in terms of prevalence and incidence, there are profound differences whether we are looking at the women population or the men population. There are diseases that have a higher prevalence in women, and this is about Alzheimer's disease. This is about depression. This is about anxiety, and we're talking about estimates of 70 up to 80%. We have that even migraine, it's a disease that impacts 80% of women and just 20% of the men population. We have that even traumatic brain injury might have a preference for the female brain with even higher consequences due to even the fact that the female brain has a thinner scalp, so it's more exposed to this type of events. Finally, we also know that when it's about late stroke, it has a higher prevalence in women versus midlife stroke, that it's more pronounced in the male population. And about even other type of diseases like dystonias or certain type of tumors, there is a predisposition for the female brain, while men are more predisposed to Parkinson's disease. Although I have to say that the differences are very mild. We have the picture of a Parkinson patient, like usually an 80 years old patient, mainly Caucasian, and that's not representing, unfortunately, reality. We have that there is just 1 million differences between men and women in terms of the total population of patients with Parkinson. And the alarming number, it's also that there is an increasing number of women that experience Parkinson's disease early in life, and we don't know if it's because of environmental exposure. So Parkinson can also occur in women while eventually still fertile, which is, something to really take into account when we meet our patients in a GP office or at the gynecologist. There might be already signs of Parkinson in early phase of our life. And this goes, related to then the impact that we have on risk factors, on biomarkers of diseases, time to diagnose, the symptoms that a disease display, the way a disease progresses over time, differences exist between men and women, but also treatment response and adherence to a given solution. This has to be taken into consideration when we design prevention strategies, when we do diagnose our patients, how we want to optimize the diagnostic flow, and finally, how we want to design our clinical trials and implement treatment on patients. Again, this is what we are trying to accomplish at the work conducted by the Women's Brain Foundation, which is now nearly a decade of dedicated research to this unmet medical need that impact women's health. We've been, in fact, one of the pioneering organizations that already in 2016 said, watch out, majority of the patients that experience Alzheimer's are women. And it's not only about being patients, it's also being caregivers. And as we said, being caregivers expose women to a certain risk of eventually developing Alzheimer's itself, because being a caregiver comes with a high burden for our body, but also for our soul, and for a risk of depression. And we know that depression is itself a specific risk for Alzheimer's disease. So it's like of a chain of, let's say, biological and societal factor that predispose women to a higher burden of Alzheimer's, both as patients and caregivers. And what we also know is that this number is projected to grow over time. I mean, estimates are quite scary, I would say. We conducted a study a while ago where we even showed that there were more than 300,000 people worldwide that will have a beta in the brain without any symptom yet, but actually having a beta amyloid deposition in the brain without knowing it. And this is about an asymptomatic population. This is men to highly likely convert over time towards symptoms of Alzheimer's disease. And we have to get prepared as healthcare professionals to diagnose, to prevent, to hopefully treat and reverse the trajectory of this devastating condition. What we know is that Alzheimer's disease starts decades before the symptoms get manifested. So as I said earlier, might be often the case, and it happened within our organization, that we had gynecologists coming to us and asking exactly this question, what to do when a woman comes to my observation with symptoms that, yes, refers to menopause, but they already speaks for an underlying neurological disorders that could be Parkinson, that could be Alzheimer. And this is real because, as we said, those diseases started 20 years before the big symptoms becomes manifested. And when I say big symptoms, I talk about a patient being forgetful, not functional anymore, and having problem in orientation in terms of space and time. But actually, the real changes start much earlier with behavioral changes, with how the person acts, and that's more difficult to be diagnosed. The story is nevertheless that for women, this is even more real because we know, for instance, that women who carry the ApoE allele, they have a higher tau burden, and tau, it is one of those toxic protein that gets accumulated in the brain and becomes the process of neurodegeneration after A beta gets accumulated. So it's a cascade of events, and what we know that for women, unfortunately, it is much tougher than for men. And this is also increasing the risk of progressions toward full-blown dementia, unfortunately. What we need to also emphasize, and I think this is very important when we want to diagnose timely and properly our patients, is that symptoms often in women are overlooked or misdiagnosed. What I'm trying to tell you is that in the female population, symptoms of Alzheimer's disease might begin with depression, with changes in behavior. My wife is strange, my mother is bizarre. And often these patients get dismissed either with, oh, come back in 6 months, we'll watch what's happening. Or they might even get a a diagnosis of depression and get treated with antidepressant. It's just a couple of years later when things worsen that finally a proper diagnosis of mild cognitive impairment occurs. And for the male population, it's kind of simpler because the symptoms in the men are more like towards aggression, being really forgetful, or it's more obvious. And usually they also have a caregiver, which is the wife, which is the daughter, that it's more sensitive to this type of changes, take it more seriously, and they become the chief medical officer of the family, bringing the patients to the observation of a specialist. Our data that I'll show you later show, for instance, that usually the female population gets later than the male one in front of a specialized doctor. Usually they get referred to a specialist much later than a man will do. We also know that the disease in women progresses twice as much as faster than the men population. We also know, as we heard before in the poll, that women have a cognitive advantage in the early stages of Alzheimer's disease, with verbal memory specifically, which means they mask the symptomatology. And when we diagnose, it's already too late. The disease is well and too much distributed in the brain, and there is little window of intervention in terms of lifestyle changes, preventative measures, or even a therapy, the success of a therapy. What we also have to say is that the scales that are used currently maybe are not well designed to appreciate these early signs of cognitive impairment, subjective cognitive decline, and maybe MMSE, MoCA, they're not accurate enough to capture what's going on in a woman, sometimes also in a man, because they are designed for later stage of the disease. Nevertheless, as I said, the women show faster cognitive decline than men, suggesting a tipping point beyond with the compensation fails. Now, this is a study we conducted at our organization in a collaboration with colleagues in Barcelona. And what we did, we analyzed the level of expression of CSF, cerebral spinal fluid biomarkers, and their association with a beta pathology on PET, so how they correlated with PET and tau in a cognitively unimpaired individual population. Interestingly enough, what we were able to observe is that men had, let's say, higher expression in the cerebral spinal fluid of biomarkers such as neurofilament, glial reactivity, and vascular biomarkers that showed a mixed component in this kind of conditions, while the female population showed a higher expression of tau. This is known. Women have higher tau deposition than men when A beta levels at baseline looks the same in specific brain regions, but this was confirmed also in CSF. And what we also learned, and this is a good news, that nevertheless the accuracy of diagnosing, so the correlation with then the PET, the amyloid PET measure in the brain, was good enough in both sexes. So there was no difference in terms of how the biomarkers were able to really pose a diagnosis of A beta pathology in men and women. Nevertheless, the other biomarkers assessed were different. And this is important because more and more we are going towards precision intervention, precision medicine, also in neurology. So we hope that this type of biomarkers will lead to novel discoveries of new treatments, but they will also help us in optimizing trial design for exactly the same. Here you see a recent update of what was already the work conducted by the Lancet Commission on Dementia. And I can proudly tell you that we were able to include also gender as a specific, well, sex actually, as a specific risk factor for dementia. Of course, this is a risk factor that cannot be changed, either we are born as a woman or as a man. Here you see that there are actually multiple specific risk factor for dementia that, in fact, if you have a deep look at them, you will notice that some of them differentiate between men and women. What I'm trying to tell you, for instance, is that education, it is actually a protective factor for not developing dementia. So the higher you are educated in terms of years of education, the less chances you have of developing dementia when you get old. But again, we know that women worldwide, they access education less than men. And we also know that women worldwide don't stay in that educational continuity like men, because maybe they don't work at some point, they leave the workforce and they don't get this continuous education over time. We also know that one specific risk for dementia is, as we mentioned, depression. And we know that 80% of people with depressions are women. So again, it's a specific risk factor for dementia for women. But we also know that there are others that can be eventually correlated to whether being a man or a woman, but the good news is that they can be corrected. So there are some lifestyle changes we can implement to reduce our specific risk of developing dementia. And this is about hair loss, vision loss, it's about high level of cholesterol, it is about sedentary life, it's about what we eat, it is about smoking, alcohol consume and abuse, it's about obesity. So there are a lot of things that can be done and changed in the lifestyle of an individual to reduce the risk of dementia later on in life. And I think that we as healthcare professionals are all responsible of sharing this simple information with our patients. Of course, changing lifestyle is not that easy, but we are at least, let's say, morally obliged to pass this type of information to patients that have a familiarity, patients that are at risk, or more in general, to patients who ask for an healthy aging and a long, healthy life. This study of ours, it's an interesting one. And again, I think it empowers us to go into a precise, specific action mode for our patients. This exercise was conducted on a patient cohort across United States and Germany. And we have been asking questions about the patient pathway, patient journey, when they got symptoms of mild cognitive impairments and then develop eventually later on Alzheimer's, how it was perceived either by the patients or the caregivers. These patient surveys gave us incredible insights on differences between men and women and what happened to them when exactly experiencing, as I said, signs of cognitive impairment. The female population, surprisingly so, for instance, was less aware of what Alzheimer's is. Men were more, let's say, conscious of what Alzheimer's disease is. The female population was being admitted to a specialized doctor later than a man patient will do. Now, which are the reasons? We can speculate, maybe because women are poorer, because maybe majority of elderly women don't have a caregiver, you know, usually it's they are widowed. There are multiple reasons. The truth is that the time to access a diagnosis was a specific diagnosis for Alzheimer's disease was later in the women than in the men. We also know that you know, interestingly, the patient survey we conducted confirmed what we already knew, that most of the time there is this misdiagnosed of women with depression while they already have, in fact, cognitive decline. And this also resulted in women then being treated during the entire disease history with more antidepressant than the male population. So women got prescribed antidepressant during the entire history of disease versus the male population, which again reflects on those disparities and maybe the fact that the diagnosis might be misled by a misdiagnosis at the beginning of the journey. Now, the time that will follow after this glimpse I've given you about how sex and gender differences impact time to diagnose, symptoms of the disease, biomarker expression, it's about understanding why. And certainly we cannot neglect that menopausal changes play a huge role in predisposing the female brain to Alzheimer's disease. We know that estrogens have a very high potential of being neuroprotective, and they also impact the entire body functions, including mitochondrial, gene expression. You know, we know that estrogen slow the epigenetic clock, and there are at the moment lots of studies aim to understand how this genetic ovary and fertility clock might impact brain health. Of course, we are at the beginning of a new era. We are starting the journey to understand how all these hormonal changes really impact brain health. What we certainly know is that a premature menopause, it is a specific risk factor for Alzheimer's disease. And here you see a study which clearly points to this phenomenon, whether it is a physiological early menopause or it's induced iatrogenic due to, you know, other medical condition that force to induce menopause in the female body. But certainly, the earlier you start your menopausal phase, the higher the risk of developing Alzheimer's disease. And we should implement all those measures to make it possible for women to have, women who don't need, for other medical reasons, an early menopause, to have a good lifestyle that will delay that onset as much as possible. Another study of ours recently correlated, for example, the estrogen with the modifiable and non-modifiable risk factor for dementia. What we know, for example, is that estrogens, when they are present and in abundance, they do lowers the LDL cholesterol component and improves the lipid profile, especially when even combined with HRT in women that are at high risk with familiarity for dementia. What we know, for instance, that smoking depletes the estrogens, and depletion of estrogen, of course, relates to earlier menopause and reduced hormonal replacement efficacy. Finally, another consideration to be done is that fluctuation into estrogen contributes to higher prevalence of depression in the female population. And as we said, depression, it's a specific risk factor, according to the Lancet Commission on Dementia, for developing dementia later on in life. So basically, these are things that we can change, that we cannot change, but that certainly they do interact with one another. And it's good to be aware of this correlation and this association of estrogen with modifiable and non-modifiable risk for dementia. Now, we can spend few reflection on the fact, based on what we just shared, that menopause can be a catalyst of neurodegeneration indeed. We know that menopause reduces synaptic plasticity and neurogenesis, increase neuroinflammation, there is mitochondrial dysfunction coming in, and of course, altered hypothalamic thermoregulation. This results in the vasomotor symptoms that we all describe when we face this change in our body, hot flashes, night sweats. Importantly, one of the first signs of menopause, it is sleep disruption. And more we believe that, yes, menopause starts also in the brain, because the earliest symptoms are really sleep disturbances, brain fog, and mood symptoms. Then later on, we will have the vasomotor symptomatics. And that's something we have to really keep in mind when we see our patients. All what I've shared with you, of course, will predispose women to have a higher risk of vulnerability to neurodegenerative disease, such as Alzheimer. Certainly, what we have to say, if we ask carefully to our women, that 85% of them will report central nervous system related symptoms of menopause, and 25% will tell that those are severe, impairing the quality of their life. Finally, but not least, and this is a sad number in my opinion, 1 out of 3 women will be considered to leave the job, the workforce, because of symptoms related to menopause. And, I think that this tells a lot. Now, what shall we do as healthcare professionals when all these things come up to our attention? I think that we have to really take in serious consideration women when they tell us that they have sleep disturbances, that they have personality and emotional changes, that they are lacking the drive, that they are nervous, that they have arguments more often, or that, there is that level of irritability that it's inside of them. All this has to be then reflected into eventually a right diagnostic approach. I advise usually to any woman around 45, 50 to have a baseline MRI, even to just check what the brain is doing and monitor over time how changes might impact the brain anatomy, the brain structure, and finally the brain functionality. This is, of course, it's helpful also to exclude structural, vascular, and neurodegeneration happening. It might also display atrophy patterns or white matter diseases. It's always a critical phase of the life of a woman that also starts, to predispose the brain to an aging process by default. And finally, we should, of course, proceed to neuropsychological assessment to detect those subtle cognitive impairment. Now, a study that I conducted in the past was using digital biomarkers for appreciating signs and symptoms of subjective cognitive decline. And the news is that, in fact, as I said already earlier, those tools are much more sensitive than current scales to discriminate whether the subjective cognitive decline is really existing and it can be objectified, right? So I hope that in the future, more and more digital biomarkers will be used routinely to discriminate those signs and symptoms. In these slides, and I heard that you can receive this talk if you want to learn more in detail. If you ask the Nestlé Health Science, they will share it with you. But certainly, where we have to pause for a second, it's how to conduct a differential diagnosis of cognitive decline and which are the diagnostic tool we have. Clinical assessment goes first. That's clear. The clinic has to talk first. And we have to do a good anamnesis to understand the family history of this person in front of us. We also have to ask what we spoke about it earlier, the sleeping pattern, the fluctuation of possible symptoms, mood disturbances, whether in the family there are cases of dementia and neurodegenerative or psychiatric disorders, and finally, how they do function in their daily living. We should take time to exactly ask how it is your day. Do you still function as a few years ago, or has something changed? And then we need to do the differential diagnostic, which starts studying underlying possible causes of cognitive impairment, brain fatigue, like thyroid dysfunction, like vitamin deficits, like the metabolic profile of an individual that reflects then the lipid and the cholesterol expression. I can't stress enough to always check for, cholesterol, lipoprotein A, to study which is with HbA1 for understanding the glucose and the risk of diabetes of a patient. And finally, blood pressure, because we can't exclude that we need to make a vascular risk assessment of an individual. And finally, especially in centers that can allow those tools to have an MMSE, to examination, meaning mental status examination, or a MOCA exam, it's a must. It's a must also just to have a baseline recording of how that brain functions at that given time, and then monitor maybe years later. Ideally, also neuropsychological assessment. If a patient comes with subjective cognitive decline or objective cognitive decline, one should certainly proceed with neuropsychological assessment if possible. And finally, we have biomarkers. We already spoke about MRI brain. We already mentioned CSF biomarker that can measure, level of expression of the so-called toxic proteins such as A-beta and tau, but we're also now having availability of blood-based biomarkers that can measure not only phosphorylated tau, but also neurofilament to basically characterize the risk of an individual and how we are in that trajectory to have symptomatic Alzheimer's disease or dementia later on in time. What we are conducting at the Women's Brain Foundation, it is an interesting study that might be of relevance to you, hopefully in the future soon, and it's about developing a so-called triage tool that can be used with patients in a waiting room and being able to discriminate which are the symptoms that really belongs to menopause versus the symptoms that are talking already for the beginning of a neurological condition that, as we said already, will have the blown big symptomatology develop 20 years later on the journey. And this came from a direct request from the ground, let's put it this way, from colleagues that were observing more and more that there were cases of women that were in the menopausal transition going to their attention, not just with the symptoms of menopause, but there was something else behind. And then they went to deep dive and they realized there is Alzheimer's, there is Parkinson, there is a depression. So this project, it's really aimed to understand how to triage and differentially diagnose what it is healthy menopause versus pathological menopause, because we have to emphasize also that there is an healthy menopause possible for women. Few words about then the second brain. I mean, more and more even lay public grasp this knowledge of our intestine and gut being the second brain we have. And there is in fact a strong intercorrelation and dialogue between the brain and the gut permanently. So via either the enteric nervous system or the vagus nerve, but certainly this also impacts then the hormonal signaling, as we know, the immune and inflammatory pathway, and all the metabolic mediators that determine our health, our well-being, but also how we age. And we will see, in fact, that menopause is associated with an estrogen decline that can disrupt this gut-brain axis. And this results into a higher predisposition, as we said, of developing certain conditions, that it's not just brain diseases, but also immunological condition. And it's about how this changed an healthy homeostasis. Now, a few words about the estrobolome. This is an important concept that reflects how our unhealthy gut bacteria population can encode enzymes that allows estrogens to be better metabolized and re-enter into the system of our body. Pose this into, let's say, easy terminology. And estrogen, in fact, do promotes microbial diversity, and the gut microbiome regulates the circulating hormones, as I just said, which makes it an important element of our well-being. Now, when we have a decline in estrogen and progesterone due to menopause, we have a reduction in microbial diversity, and even the functionality of the intestine will change, which relates also back to the change in the estrobolome, the capacity of those enzymes to work on the hormones in our body and allow them to re-enter into the circle and do the job they do. And this can then also explain why certain women have maybe a stronger estrobolome and a stronger microbiotic population and have less of menopausal symptoms versus women that have it worst. So I think that it's also for us very important to give elements to women on how to maintain an healthy microbiome and healthy estrobolome, and how all this impacts aging and brain health trajectories. A good gut dysbiosis, a gut microbiome that doesn't function as it should, can bring us to chronic low-grade inflammation, immune dysregulation, altered gut-brain communication. And that's true for men and for women, actually. Certainly for women even more, because we said the estrogens is really influenced by that. And this predisposes, once again, women to diseases like Alzheimer's, Parkinson, but also psychiatric disorders such as depression and anxiety. So what we have to do, because we can, as we said before, implement lifestyle changes to reduce the risk of dementia in both men and women, actually, but certainly a lifestyle that also have a diet, that it's a good diet, especially a Mediterranean diet or plant-rich diet, can impact our well-being. And we are, I think, I repeat it again, in our profession, morally obliged to share this knowledge with our patients, with our men and women. This allows a better weight regulation, reduce the vasomotor symptoms of menopause, such as hot flashes, and eventually also delay the onset of menopause. So it's not just about women in the perimenopause and menopause. Actually, this should start with young women already, right? To tell them how diet, it's important, how not exceed with alcohol consume, it's important, how stop smoking that impacts estrogen level, it's important, etc., etc. Finally, this will also have an impact on how we experience the symptoms of menopause during that transition, right? It can be a relief of symptomatology. And finally, but not least, I will also talk briefly on how isoflavones can impact this hormonal, let's say, equilibrium. Now, what we need to say, it's also that one study pointed to the fact, it's the Zoe Predict study, that women have more than 32 species of bacteria that might be linked to menopause, and how diet influences menopause and vice versa. And as we said already, an healthy diet can really improve our microbiome and allow the estrobolome to work better. Now, this is evidences of another study that point to the fact that Mediterranean dietary approaches do stop hypertension, lead to reduce hypertension intervention, and they have a benefit also on cognitive decline, which is profound, right? And what we have to emphasize, though, is that we need more evidences across races, and we need also a precision approach. So these are the first learning of these longitudinal evidences that point to the impact of diet or more in general lifestyles to the risk of dementia and cognitive decline. This is another one that I found really, really compelling. Again, it shows like Mediterranean diet can reduce the risk of a certain type of strokes in women. And this was a huge cohort that showed that those women that followed a Mediterranean diet have a lower risk of total ischemic and hemorrhagic stroke. Again, very, very important findings. Certainly, when we speak about menopause, women, brain health, we have to look at vitamin B6, vitamin B12, vitamin D, iron, omega-3 fatty acids. It's another study shows that women actually needs more of omega-3 fatty acids than the men will do, especially if they have a familiarity for Alzheimer. And I think that's very important to take into account because it will reduce their risk of the disease that we mentioned earlier. It's about now probiotics. Certainly, we know that there are benefits also in probiotics, and we know that probiotic formula that contain, for example, bacteria with beta-glucuronidase activity will help in maintaining estrogen levels in healthy postmenopausal women. That's really easy to implement and change outcomes. CP2305, it's a parabiotic, for example, also improves psychological symptoms in menopausal women. So it has an impact on mental health and brain health. Of course, I mean, more studies are needed and we have to be cautious, but certainly these are first evidences that really point to something that can be concretely done, such as soy isoflavone supplementation that can improve cognitive performance and cognitive resilience, including visual memory in the patients and women who actually took it. Caveat, it's that this study was conducted in women that were younger than 60 years old of age, and that went into this treatment for a short period of time, less than 12 months. And those evidences were generated in a non-US population. But again, it's a beginning of studying how all this can give an healthy aging and reduce menopausal symptoms. Then there is the big elephant in the room. This is about hormonal replacement therapy, highly debated. Shall we prescribe, shall not prescribe? Well, what we in fact know from science is that there is not direct correlation between HRT and cognitive performance. In healthy women who initiated HRT close to menopause, randomized controlled trials demonstrate neutral effects on objective cognitive performance. Certainly, we have that all the, let's say, improvement was indirect and mediated by better sleep and reduced vasomotor symptoms. So I would say that menopause, can benefit by HRT, especially for the vasomotor dysfunction, for what we already know they act upon, but again, cognitive performance, also from a large cohort study using UK Biobank data, doesn't necessarily show that there was an association with cognitive benefit. And that's important to keep in mind. Physical activity, I'll be fast because I think we are coming at the end of our talk, but physical activity on the women population shows benefit in terms of cognitive performance, brain health, and even menopausal symptom, can even delay the onset of menopause on women. So I think that prescribing or recommending physical activity to our patients, it is absolutely a must. Women that walk daily, they even have an enlarged hippocampus, which is extraordinary in my opinion, because it really showed the benefit of physical activity, walking, and what we also know from indirect evidences, that's also for me something I've learned with the work I've done, that in general women move much less than men. And I don't know if this is knowledge that it's with each of us as healthcare professional. Now, I think we learned what has to be done. I won't go into the detail of this slides because we talked a lot about measures that can be implemented. Here you have again a study pointing to the benefit of physical activity, where we show with the study conducted with the London School of Economics that we can reduce 14% risk of dementia by recommending people do physical activity, especially women, bringing the level of physical activity of women to the level of men, not even higher, just to the same level of men. Because as I said, women move less. And this of course reflects then in reduced costs for the healthcare system. So it's not just the life of the individual, but also the entire ecosystem. Another study we did, I think it's again point to the fact that exercise shows greater benefit in women as well as in cognitive stimulation therapy. So women really benefit of cognitive stimulation therapy more than men. Unfortunately, preliminary evidence shows that disease-modifying treatment seems to be less beneficial for the female population versus the male population. I conclude with one big finding. We said that there is the big study of McKinsey presented at WEF that said 1 trillion return of investment can be generated if we do women's health research. Here you see a deep dive of that study that we did always with the McKinsey Institute of Health, and 250 billion can be generated just by doing research on the brain of women. So it shows that actually this organ is one of the most underserved, understudied of the entire female body. And I recommend to read into this study that speaks about the women's brain capital, a newly coined terminology. This is one of the many books that we have been generating at the foundation. You can scan the QR code and access all the books that we've been able to produce. This is our educational campaign. We have also an academy that you can join if you want. This is an awareness campaign, sorry, not educational campaign. Education, we do it via the academy. We do then awareness campaign as this one. You can again scan the QR code and join our effort and our community. And with this, I think I'm done.
Dr. Antonella, thank you. That was an incredibly helpful and informative webinar. I think everybody took a lot away from that. We have so many questions in the chat and we have very little time. So I know we have an offline conversation that we'll try and answer some of these questions as well. We will be recording them, so I'm sure we can add them to the platform once they're answered. But I think what we should do, I was going to do a poll, but I think we're going to just skip ahead to answering some questions with Dr. Antonella to see if we can get as many of these done in a shorter period of time as possible, just to help all of you. We've had all sorts of questions, Dr. Antonella. One that's close to my heart, and I think everybody at Nestlé Health Science, is how important is it for us as practitioners to partner, for example, with dietitians to make sure that, you know, we're really addressing the nutritional needs of women during menopause? Any thoughts around that yourself?
It's a must, and I think we need to think about a 360-degree approach, which goes with specialized colleagues in nutrition and diet measurements, but it's also working together with psychologists, it's working together with neurologists. So I think that we will see more and more in the future an holistic approach to women's health, where all those expertise will be combined. And I can't recommend enough to have that mindset, because sometimes doctors, and sorry for saying that, dear colleagues, we should acknowledge sometimes we work too much in a silos. And I think to expand that cooperation with distinct type of professionals will benefit our patients indeed, and reduce also our workload and see a successful outcome on the patient. That's what we want.
Perfect. That's great to hear. We had quite a lot of questions about ApoE4 gene as well. Dr. Antonella, any specific recommendations from your side? And then also, as a caveat to that, somebody wanted to know, how important is ApoE3 gene in this? Is this not really a consideration for women as well? So I'm just asking the question because it came up in the chat. If you have any insights there as well.
A very fast response given the time, and we can deep dive later. It's that especially when you have familiarity for Alzheimer's and dementia, an ApoE assessment, gene predisposition of a woman, but also of a man, it's essential, because it will allow us to understand which is the real risk of that patient to go towards that trajectory later on in life. And it's now very easy to be done. It is not for high costs. So I usually recommend it very much so, because it allows us to really then justify those lifestyle changes that we want to implement to minimize the risk of developing dementia, or at least to delay the onset of the disease, because not every time you can, unfortunately, but at least you can do things to delay the onset. And I think it's great news.
Great. One of the other questions we had was early detection of brain function decline is great, but there's very limited treatment for Alzheimer's. So just wondering what your suggestion would be regarding
Two
early treatment
comments.
for dementia.
Absolutely. 2 comments on this I allow to do. First of all, we saw at lifestyle changes and how they can reduce the risk of developing dementia, which is about, I think now we calculated 65%, before it was 45. It's huge. So if we would be able to really implement all those changes, imagine to reduce your individual risk of that amount. So that's already for me therapy, right? I mean, if I can tell a patient, keep your hypertension, cholesterol, hear loss, visual loss, depression risk, non-social isolation, keep moving, diabetes, obesity. This is really profound. And we can delay the onset of those symptoms. When it's about treatments, I agree, we need better treatments. But the good news is that after 20 years of research, we have been able to approve medicaments that go in the brain and remove the plaques from the brain. Now, what I will do if I were one patient to be, and if I could change the world, which we can sometimes, because there are, of course, regulations and guidelines that needs to be respected highly so. But more and more, we have preventative studies that use those molecules, those antibodies that removes the plaques earlier in the disease trajectory. I've been doing neuroscience myself for many years. I work with dementia patients for 6 years. And actually, when the symptom starts, the brain is already compromised to a level that no treatment really can do the miracle. So in theory, we should do like with cholesterol, right? We start a preventative measure for cardiovascular diseases with lowering lipid agents decades before a cardiovascular event might or might not occur. So what if, even in Alzheimer's, we will start to prescribe those drugs decades before the symptoms manifest? And this is where we can act. We need more evidences, we need more science. Those trials cost a fortune and also implies the sacrifice of the life of those who take part to these trials. So it's also important to encourage our patients to join trials of any kind and remind ourselves that this implies a sacrifice from their side as well. So acknowledge that a lot.
Brilliant. Totally agree. Thank you, Dr. Antonella, and thank you to everybody who joined us on the webinar today. We value your time as well, and we really hope to have a lot more of these coming up. But we'll answer some of the questions we weren't able to answer in our offline conversation we will be having with Antonella. And really, thank you for your insights, Dr. Antonella. And please, anybody who is interested or has any additional questions, please reach out to us at Nestlé Health Science. We'll be more than happy to do that. The recording will be available on the platform as a video on demand. So any of you who might have missed something in between, who need to access the video again, feel free. But let us know if there's any additional things you need from us. We'll be more than happy to support. Thank you everyone for your time today and enjoy your evening. Bye-bye.